So we live in a very fortunate time. I mean, have multiple therapies for macular degeneration. They all block VEGF. Why don't we go through sort of what are the differences between our different drugs, and then we'll go through some of the comparison studies. So, Atul, you want to run us through some of the mechanism of action of these new drugs?
So there's basically there's Macugen, which was a specific VEGF 165 subtype A blocker. It's a monoclonal antibody. Then there's Lucentis and Avastin, which are humanized monoclonal antibodies, which are pan-VEGF against 165A. And then there's the VEGF trap, which is a pan-VEGF inhibitor as well, and it also binds to placental-derived growth factor as well. So that's kind of been the evolution. It went from a specific type of VEGF to pan-VEGF blockade to pan-VEGF blockade plus placental growth factor derived blockade.
So, in your mind, you have these four drugs. How are they different in your mind, just on a MOA type of basis?
I think Atul did a very nice job summarizing the differences between these molecules. There are other things worth mentioning. First of all, the size of the molecule, the molecular structure. Ranibizumab or Lucentis, about 50,000 Daltons. Aflibercept or VEGF trap or Eylea, 100,000 Daltons approximately, and Avastin or bevacizumab, 150,000 Daltons. But there are other differences that are also really worth mentioning. First of all, placental growth factor. Aflibercept or Eylea is the only molecule that inhibits placental growth factor. My opinion is that this helps at levels that we haven't really assessed yet, whether it's durability or in cases that are recalcitrant to previous generation anti-VEGF agents, that extra target, the ability to inhibit placental growth factor may be a benefit of Eylea compared to older generation anti-VEGF agents that don't inhibit placental growth factor. But VEGF trap or Eylea, on the other hand, also has one-to-one stoichiometric binding. Ranibizumab may form dimers, Avastin may form long daisy chaining, and you may see multiple Avastin molecules bind several VEGF molecules. And these differences may confer differences that we're still learning, whether it's in side effect profile, pressure increases, who knows. So we really don't know the clinical significance, but there are distinct differences between the three popular agents that are certainly worth mentioning. But also binding affinity. At the most basic level, there are distinct differences in terms of binding affinity to VEGF.
So, Justice, in your mind, do these differences between the drugs, do they translate into any type of longevity differences?
I think we're still learning about that, and I think that it may vary from patient to patient. I had a patient come in for a second opinion who had around 30 injections in both eyes right before aflibercept was approved. He'd had both Avastin and Lucentis, and essentially he had it down to one of them lasted 14 days, one of them lasted 8. And then when we switched him over, he said this one lasts 21. And so. And the first ones weren't in the order I expected, and so he was and over time we've kept him on Eylea and he's done really well, and now it works for 28. So I think there's some variability from patient to patient. I think that one of the other things, and I think this also may go to some of the affinity binding affinity that each of these drugs have, is there may be a difference in potency, and that may translate some to durability, but it may not be inherent durability, and I think those are some of the things we'll see over time. In the VIEW trials, we saw some of the seesawing of the OCT, but the visual results were outstanding, and that didn't translate. And ultimately, this is a chronic disease that goes on for years, and all of our trials essentially are cutting off at 2 years. And so I think it's very difficult to assess what does it mean long term for some of the fluctuations.